Hello and welcome to today's webinar. Thank you for joining us. I'm Rebecca Cherry, Senior Associate in the Medical Negligence team in London. Our speakers today will be providing their insights into rehabilitation following a spinal cord injury and the impact of the pandemic on rehabilitation. First, we will hear from Mr. Manish Desai, Consultant in Spinal Injuries and Rehabilitation Medicine at the London Spinal Cord Injury Centre. He will be followed by Jane Simmons of NeuroConnects, then Joe Evans of Unite Professionals, and lastly our client, John Adams. Just a few matters of housekeeping before we get started. Thank you to those who have already submitted questions. To submit questions during the session, please use the Q&A function on your screen and we will answer them at the end. When submitting questions, please do include your name and email address so that we can respond directly post-event if we are unable to address your question during the event. A recording of the event will be circulated afterwards, and towards the end of the session, we will be posting a feedback link. Please do take a couple of minutes to complete this. Anne Kavanagh, who is a partner in the Medical Negligence team in London, will now introduce our first speaker. Thank you.
I think you're just on mute there, Anne.
Thanks, Becky. Our first speaker today is Mr. Manish Desai, who's a consultant in spinal injuries and trauma rehabilitation and leads the Regional Specialist Rehab Service at the London Spinal Cord Injury Centre in Stanmore, in addition to which he's a senior lecturer in musculoskeletal sciences at UCL. Holistic, multidisciplinary and patient-centered care are the core values of his practice, and I'll hand over to him now.
Thank you very much, Ran and Arvind Mitchell. Good afternoon, everyone. I'm Manish Desai. So I would just share my experience or our unit's experience during COVID-19 pandemic last year and a little bit of still going on with restrictions. So let us go to the statistics. So next slide, please. Traumatic spinal cord injury in our country, approximately every 8 hours, one case is registered on national database, and total there are 1,000 cases per year. Approximately 40,000 patients are currently living with the traumatic spinal cord injury condition in United Kingdom. Now, this we are talking about the trauma, but there are other patients who have non-traumatic spinal cord conditions, which includes myelopathy, tumors, infections, degenerative diseases, inflammatory and post-operative conditions. Recently, we saw a surge in myelitis-related spinal cord injury, and we were not sure whether that was a variant to COVID or it was a transverse myelitis, which we see in our practice. As you all are aware, we are 12 specialist centers in the United Kingdom, and we share almost similar principles for the care of spinal cord injured patient, traumatic or non-traumatic. Next slide, please. So in COVID-19 pandemic, what happened? Did we stop? Because London was I would say London was the hotspot. The whole London was the hotspot. The thing started growing up around February. So we were having regular updates from the trust communication department, and things were gradually changing over February up to early March. Did we stop? Actually, we didn't, because we continued to follow the local trust protocols to minimize the spread and impact. There were patients with aerosol generating procedures, some unwell patients. Those group of patients, as a team, we decided that anybody who attends that patient would provide a comprehensive care. That means if patient requires turning, patient requires hydration, patient requires medication at that time, that person who is wearing PPE would provide that care. That was just to minimize the spread risk and also to cut down the use of the PPE, because if you remember early days, these were not in abundance available in the units. We very early our communication department and IT they started providing us the technology for virtual meetings. We initially used a lot of us used NHS Anywhere software for video consultations and outreach visits. We also use that Microsoft Teams and Zoom for diagnosis and prognosis, case conference, goal planning meetings. Not only that, we had to shorten length of stay because we didn't want to get the patient affected with virus who were virus free, basically, because it is a small hospital and a small unit. It is difficult to have isolation rooms for every patient. Some rehabilitation was provided at bedside. Visitors were not allowed for a few months. The most important thing is that our team provided excellent psychological support for all inpatients because we were their family, we were their relatives, we were their next of kin, and that was very important for the show keep going. We provided basic rehabilitation, and why that was the case is because there were a lot of challenges. By the time end of February, there were a lot of training got started by the trust that how to use PPE or how to wear PPE and what comes first, what comes second, fit testing. And of course, the fit testing went for evolution. Initially, we had different kind of kit. Then the trust bought very sophisticated fit testing machine to make sure that all healthcare professionals or everybody in the hospital, they remain safe as far as possible. There were a few members of the staff, not only in my unit, wider hospital, radiographers, porters, healthcare assistants, they were actually fit tested, that they were not, any mask was not appropriate for, and that was a challenge for everyone. We received the first COVID patient, not received, that patient became COVID positive on 21st March 2020, and that was the first patient on spinal unit. There were already patients undergoing rehab before the wave started, and they were allocated a length of stay, and they were not quite happy to undertake discussions about shortening of the rehab and go home and come back. But we managed good few number of patients to be discharged earlier than they were planned, and we did get them back for top-up rehab, and we completed our promise. We kept our promise. Changing protocols, because in those days, February, March, April, every day there was Public Health England would issue new guidelines. Initially, if you all remember, the masks were not compulsory, then the mask came in, and then PP, and then isolation of patients. The main problem in all spinal units, I would believe, is the limited isolation rooms, because what you do when the patient was negative, then tested positive, where do you keep that patient? Because the rooms are already occupied by other patients, and we don't think about only COVID, because patients with MRSA, CPE, all those kind of sometimes C. difficile, they all need to go into isolation room on top of the COVID. There was a risk of shortage of PPE at some point, and we were advised to use it wisely. Staff shielding, staff isolation, some people becoming symptomatic or very unwell. So there was a range of absence from 1 week of isolation to many weeks or maybe months, because some staff became very unwell in the first wave. That led to the shortage of manpower, therapists, nurses, and we had to literally close down some of our ring-fence beds then, because we could not cope with the situation. There was pressure to take more SCI patients, spinal cord injured patients from major trauma centers, even though they are not ready to come in for rehabilitation, because they wanted to admit more COVID patients. And that was a big challenge for us to keep the beds moving. Next, please. Thank you. So then we passed that test July 2020, and still we had further challenges ahead over the whole year. Like then we came to know that still there were restricted theater and ITU facility for non-COVID patients. A lot of restrictions on interventions, like our hospital is a leading musculoskeletal intervention radiology as well as musculoskeletal specialist, and spinal cord injured patients would require those interventions from time to time. So that was quite limited. Radiologic protocols were quite tight to reduce the spread of the virus. Previously, I would book an X-ray or MRI, it would happen within 24, 48 hours. That was no more the case. Patient has to be booked in advance. They have to be informed. COVID test positive, negative, a lot of admin work to be done. There was the big challenge for our outreach team, because they stopped going to the major trauma centers because they were the hotspots, and all the consultations for new admissions, potential admissions, were via virtually, and there were limitations because sometimes you do miss the important information and patient arrives on the spinal cord injury unit who is not yet fit to undergo rehabilitation, and that would just occupy a bed in this critical scenario. There was a challenge because a patient tested negative, comes in for admission, and then after a week or 2 weeks, when you regularly test them every week, they show positive COVID test. And I remember one of my own patients actually challenged us that how on earth she got contracted virus, and it was difficult to explain that this is a pandemic, and this even if you close the doors or windows, that doesn't stop virus spreading basically. So therapy sessions, as we said, availability of the staff was important to provide the therapy staff. But the important thing is that we never stopped. There was a limited social and peer support, no more group sessions, and shorter length of stay. But we always reassured that you can come back for top-up rehab, and we kept that promise throughout the year. I mean, this year. Outside the hospital, that is, we struggle. We have got case management team, which is excellent, but we struggle because most of the people in the social services and outside the hospitals were working from home. So how to contact them? Whether do they have the same kind of technology available as we have? Home assessments, community assessments, discharge planning, equipment, procurement or provision for safe discharge, post-discharge community rehabilitation. That was the most important aspect in the discharge, which I think patients suffered because they didn't get that same intensity of rehab following discharge. Referrals to other medical specialty, it was difficult because people were morely working towards COVID rather than non-COVID conditions. And also routine post-op follow-ups, like patient which I admit for cervical spine trauma, thoracic spine, they would usually have 6 weeks post-op follow-up in St. George's or London somewhere, Queen's Romford. Would I send that patient back to that hotspot? So that was another challenge, and we managed few patients with telephone consultations. So we managed few by our in-house surgical specialists to see them rather than sending them to the hotspots. Next up, please. Next. So this was very innovative. I must say that our center manager, then once the restrictions eased around June, July, we bought this gazebo, and we formed a rota for patients, and then we gave them time and day, and then one family was allowed with all precautions and social distancing to meet the patient in our beautiful garden on outside of the unit. There were notices like this everywhere on the unit to reduce the contact spread and maintain the social distancing, etc. So even offices of the consultants, case managers, junior doctors, more than certain number of people would not be allowed at the same time. And that was very much rigidly followed, I must say, by our unit. Next slide, please. So I would say that was a challenge which my unit or our unit converted into an opportunity, because this year, irrespective of the challenge and shortened beds, less length of stay, actually we admitted 103 first episodes, and we cleared our waiting list, which was quite a big achievement, I would say, irrespective of the problem. We saw 249 outpatients via virtual or telephone consultation. That was another landmark achievement, I must say, over last year. The year before we had 104 first episodes, 2019, and year before you can see 96. So we definitely saw more than. We continued doing urodynamics, because that's the main service which provide from the urology point of view. We continued doing ITB refill. We sometimes our colleagues would go to the patient's house to do the refill if they feel unsafe to come to the unit. We continued face-to-face consultations for satellite services. Of course, there was no urology elective surgery, and we stopped ring-fence bed admissions for a few months when there was acute phase going on. Now, people would be interested about the private rehabilitation, and I will just touch base because there was no clear-cut pathway how to manage this, because there was a one-like umbrella kind of the restrictions, and there are very few private rehabilitation units who could actually undertake spinal cord injury patient, especially in this crisis or pandemic. So I share my experience with the London-based and one outside the London, 2 total units. So they had their own protocols. In fact, we were in one of the units, we were restricted to visit the patients if we have got a patient there. And we would do most of the time telephone review or virtual review unless the patient is really unwell and needs to see them. Obviously, some of the beds in the private units were contracted by NHS services for elective work like hip, knee replacement, etc. And I felt that where is rehabilitation here? Nobody talked about rehabilitation, or nobody ring-fenced those private beds for acutely injured patients with spinal trauma who would require rehab when the NHS spinal units were undergoing crisis. So that actually was not there. Also, I would say that everything was quite chaotic, because routinely without pandemic, I do see sometimes the insurers would fund certain patients for interim rehabilitation or to fill the gap between transfer from trauma center to NHS spinal unit, which I saw there was lack of that provision, and we didn't hear anything about that during the whole year. So that was quite surprise to me. Next slide, please. Thank you. So here on March, I think we are getting better. Everybody is vaccinated. Most of them who wanted vaccine has been vaccinated here. We have reopened the top of rehab beds and everything is up and running. All our pathways, metastatic cord compression, cord equina, polytrauma, specialist spinal rehab, 4 or 5 pathways, including ring fence beds, everything is up and running. We are gradually reopening clinics. Still 4 people are allowed, but I think from next week the things are a bit changing and we are seeing the brighter future. Challenges ahead, I would say the psychological health of staff and patients, because a lot of in London, I would say, and outside the London, a lot of staff everywhere in the hospitals, they are overseas people, and they have got family and friends overseas, and they haven't been able to go anywhere over last, I would say, 13-14 months. So that has really affected everyone, and people are worried about their relatives somewhere else. And we are hearing about third wave, so that is also a kind of a challenge. Next slide, please. So we have got a lot of, this is a tree, blossom tree in my hospital premises, and we have got a lot of hope this year. Already half of the year is almost gone, but thank you very much for listening.
Thank you so much for that really helpful insight, Mr. Desai. It's an interesting year for everybody. I have the pleasure of introducing Jane Simmons, the clinical lead and centre manager of the Hemel Hempstead NeuroConnects, a not-for-profit organisation dedicated to providing activity-based rehabilitation for people with living with partial or complete paralysis. Jane's background is she was a physiotherapist, and prior to working at NeuroConnect, she specialised in spinal cord injury rehabilitation at the London Spinal Cord Injury Centre for 6 years. Now she mixes the clinical supervision of clients with the development of services offered by NeuroConnect and acts as a link with UK spinal cord injury centres. She's going to provide us with her insight as to rehabilitation and what NeuroConnect can offer. Over to you, Jane.
Hi there. Thanks very much for the introduction, Jessica. So yeah, hopefully I can give a little bit more of a community perspective about the last year. But firstly, a little bit more about the organisation that I work for, just to explain. So as Jessica mentioned, we're a not-for-profit organisation. We were set up in 2013 by our chief executive, who has a spinal cord injury. And from his experiences with a spinal cord injury, he wanted to improve outcomes for people with spinal cord injury. And that saw him open our first centre, which was in Hertfordshire. So I joined in 2014 and have been there ever since. Next slide, please. So we initially opened up in Hertfordshire, but over the years we've grown gradually. We now have centres also in Gatwick and in Bristol. We work with adults and paediatrics, and they're all outpatient neuro rehab gyms. The type of rehabilitation that we provide is very similar to lots of neurological rehabilitation centres, but there are some differences. And the type of rehabilitation that we do often comes under the umbrella term of activity-based rehabilitation or activity-based therapy. And that really means specific to spinal cord injured individuals, that we're trying to optimise neurological recovery for those people. So trying to give an example of how that's slightly different. If we're working with somebody, a paraplegic who's doing some shoulder exercises, something strengthening or some boxing work, we'll try and do that in a standing position if we can. So using supportive standing equipment like body weight support, or using a standing frame, and doing the exercise in standing. And the reason for that is that we're really multitasking then. We're asking the person not only to strengthen their shoulders, but that we're challenging their trunk and their core muscles. They're also weight bearing, which we know has lots of benefits. They're getting a prolonged stretch through their legs, which again can be difficult to achieve for people. Exercising in standing is much more cardiovascularly challenging, so the system's having to work much harder, and that's really great at helping people to adapt after their injury. So even though we're strengthening the shoulder, we can also then see gains in other areas like sitting balance or their function. And above all, it gives the individual the opportunity to try and challenge those paralysed muscles. We know that if you do nothing, nothing's going to happen, but if you do something, then something may happen. Other ways in which we're different is our skill mix of the staff that we have working with us. So we have healthcare background professionals, so physiotherapists and occupational therapists, but we also have exercise professionals, so people with qualifications in sports science, exercise physiology and sports therapy. And I personally, having worked that way for quite a long time now, can really see the benefits of working in that way. And again, another example to explain why is if you take someone who's used to working with athletes, they're looking for really small gains in people. So a 1% change in someone's strength or their stamina can lead to really big changes in their performance. And the same applies to people with neurological conditions. Even a really small change in someone's strength or endurance can lead to gains in function and independence and quality of life. So we really see that when we have staff working with clients who know how to make small gains and how to work their programs to make sure that every little bit counts, it makes us a really great team. New slide, please. So this just briefly talks about the vision that's been the same since I joined NeuroConnects, and it's really about trying to provide the best possible rehabilitation in an affordable way. So we're a not-for-profit. We also have a charitable trust associated with us, and one of the ways that we've been working towards achieving our vision is through something called the Step Up scheme. So this has been running for 6 years now, and it means that when anyone's being discharged from hospital after a spinal cord injury, they can come and have their first 6 sessions free with us. So NeuroConnects underwrites the cost of that, and it just helps people as they're leaving hospital to bridge that transition back into the community. Also on the mission there, you'll see that NeuroConnects is aiming to contribute and facilitate neuro-restorative research. So next slide. Just really briefly on that, we're currently running a research study using transcutaneous spinal cord stimulation with activity-based therapy in chronic spinal cord injury. So we've got 12 subjects. I think we've recruited 9 or 10 of those, and we're underway. We're about 1.5 years into the study at the moment. Which has been really interesting. And we've also had a couple of other studies that are now completed, similarly looking at transcutaneous spinal cord stimulation. So again, just trying to push forward and evaluate technologies to find out what's going to be the most beneficial for individuals with spinal injury. Next slide. So just really briefly before we move on to talk about the important bit, which is the impact of the last year, just to mention that NeuroConnects is the only international affiliate of the Christopher and Dana Reeve Foundation, which is a network of sites that are trying to deliver therapies that promote functional recovery. So we're trying to stay linked in internationally just to make sure that as new technology arises and is developed, that we're evaluating it and putting it into practice. Next slide. So yeah, the important bit, the last year, when the first wave struck us in 2020, we closed for 3.5 months during the first UK lockdown. And that forced disruption to services let us see firsthand the implication of losing rehabilitation services for individuals. And when we opened up again in the summer, we saw lots of things that we expected to see. So we saw that lots of the clients had lost some of their fitness, some endurance, some strength, some had put on a bit of weight, some were experiencing a reduction in their quality of life, their well-being. But I think that reflected the population as a whole, and it wasn't such a surprise to us because it was a tough time for everyone. But alongside that, We also saw some more worrying things in our clients. We saw some losses in function that maybe we weren't expecting. So again, a couple of examples: somebody who was walking independently with no aids before came back in using 2 sticks, and someone who was going out independently in their wheelchair had lost the confidence to go out by themselves. And there were a few other examples of people, and that really made me reflect on particularly the difficulties faced by people with a spinal injury and how difficult it is to maintain their current function. So it reminded me, if someone has an orthopedic injury, a fracture of a leg, pelvis, even a spinal fracture, once that's healed and the rehabilitation period's finished, they can go on and live their life sometimes with very few consequences of their injury. But with spinal cord injury, that doesn't happen often. That there are these threats that are ongoing and existent through the whole life of someone with a spinal cord injury. So I'm sure lots of you will be very familiar with them, but things like contractures through spasticity and lack of movement, developing cardiovascular disease and diabetes, mostly through inactivity. Musculoskeletal injuries are common, and a good example is the shoulder, where people are so overly reliant on their shoulder muscles for propelling and transfers, and if they're not strong and they're not keeping those muscles strong, they're more prone to injury. And obviously pressure sores as well, coming from impact of being sedentary and circulation issues. So I really reflected that managing and maintaining just a level state for people with a spinal cord injury is really, really difficult. And for any individual with spinal injury, those things are time consuming, they're effortful, and it needs an awful lot of motivation on an ongoing basis for that person. So it made me reflect that support is so important for people, and obviously the support needs to be appropriate to the individual and the kind of threats that are relevant to them, and whether that's through centres such as ours, where we can help address some of these threats and keep things at bay, or whether that's having the provision of a PA or a carer to mean that someone's able to go swimming, or whether it's having someone to drive them to an activity or a sport, whatever it might be that's relevant for the individual, that support throughout their life is so important. And we know that if somebody loses track along the way, if they have a particularly difficult period of time, such as maybe in the last year when the COVID pandemic's been underway, and they do kind of drop off the treadmill a little bit of managing all these things, once these secondary consequences kick in, they can be irreversible or very difficult to change. So for me, I think the key message is for anyone involved in commissioning a reminder that for the individual, for their families, their employers, and for health economics, that lifelong and flexible support is key to people with spinal cord injury. And that my honest reflection is that rehabilitation doesn't ever really end for these people, that they have to stay constantly on top of all of these symptoms to manage them. I think that's probably all we have time for now, but hopefully some questions at the end.
Thanks, Jane. That was very interesting. I'm delighted to introduce our next speaker, Jo Evans. Jo is the founder and director at Unite Professionals Case Management. They're one of the country's leading case management providers. Jo is an OT by background with over 20 years of experience working in the NHS and private sector, and she leads a dedicated team of over 30 case managers. So Jo, over to you.
Thank you, Channy, for that introduction. Today I'm going to have a look at the case management reflection on advocating for individuals who sustained a spinal cord injury during the pandemic. There was no textbook to guide us on this. The client I'm going to reference with her consent was a 52-year-old lady living in a mid-terrace house with her dog, 2 sons and a husband, and she was admitted to a major trauma centre in July 2020. When I've reflected with her on her key experiences at this time, her reflections were that the most significant feelings were her inability to have her family near her. She was in the major trauma centre for 6 weeks, and reflecting on what Mr. Desai mentioned earlier on, this was a significant, had a significant impact for her. It wasn't until 5 weeks into her diagnosis and time in the major trauma centre that the family were able to come and see her through a window and get some appreciation of the significant life change they were all going to undergo. She recognised the skeletal staffing, again Mr. Desai mentioned that earlier on, that many of the major trauma centre staff had been repatriated or redeployed, I beg your pardon, to community centres or ICU, or were ill themselves. The feeling of isolation, incredible sense of isolation, lots of questions to ask, not many staff around to try and assist with some answers around that, a lack of information, and that wasn't, that's not a defamatory statement, that was just the crisis at the time impacted on information exchange and the amount of physical support that she could receive during that time. As a case manager, we would usually be instructed very, very early doors to maybe in-reach into the major trauma centre, whilst that transfer from the trauma centre into the regional spinal injuries unit progressed. But we received the referral at 6 weeks as the client was transferring from the major trauma centre to the spinal injury unit. Again, developing that therapeutic relationship was somewhat challenging because you're developing that relationship in a two-dimensional sense rather than being able to meet with the family, meet with the client, meet with the clinicians during that transfer and make the transfer into the unit as seamless as possible. As a case manager, obviously you have an extensive toolkit of skills, but that had to be modified, it needed to be adapted. Again, there was no blueprint for that. Needed to go away, keep in touch with the NHS England guidelines on the pandemic, and make sure you were informed and current. I was familiar with the spinal injury unit staff, which helped in that transition process. I was aware of their protocols and the pathway of rehabilitation that the client would be entering into, and being able to support the family to understand that. I understood the commercial dynamics of the client's claim at the time, where there was liability unresolved and still being discussed. So early doors, and I think Mr. Desai mentioned that he felt that insurers were quite late in becoming involved. I was very aware of that, having had the late referral. So very early doors, asked all parties, the defendant lawyer, the claimant solicitor and the insurer to come on to a call so we could establish what I could do in terms of resource and what I could have available to me, especially thinking about the ability to get the family to be in the centre, even though they weren't able to physically be there. So getting laptops sorted out, IT, platforms, Mr. Desai mentioned before, platforms of MS Teams or Zoom, these things needed IT support to set up, to familiarise people with, so that the boys could be with their mum and understand the transition of that, and also the client's husband to be involved in some of the MDT decisions being made and discussed around her now care, her rehabilitation, disruption or not disruption, and the future needs of the family and the client. I had regularly worked with the health and statutory teams in that regional area. So as a case manager, again, Mr. Desai mentioned that disparate access to social services, the other community support teams, rehabilitation, often staff within the unit. So again, I was able to use my case management time to engage with all of those people to move on. Sorry, Becky, I haven't asked you to move on. Please move the slides on. I'm not multitasking very well here. Yes, so if we could go on to the next slide as well, please, Becky, that would be great. And in fact, we can move on to the next slide. So what happens when you don't have a blueprint and your resource is low? Well, you need to ensure that you have effective communication with the client and the case manager and the MDT. I touched on that before. So making sure we had resource from the insurer to have a virtual platform to talk, ask questions, in order that I was also able to support that statutory pathway, the NHS pathway. I needed to work creatively and intelligently to provide the possible and maintain that NHS pathway as far as possible. There were many staff not able to be in the rehabilitation unit, so how could we creatively support the possible of rehabilitation? If they couldn't provide it, could I ensure that there was funding available to do that, and ensure that, as I said before, the clients were within the team, the MDT. Next slide, please, Becky. I was referring to myself as the conductor of the orchestra. The score was known, but actually the orchestra was very unfamiliar to me and the NHS team at the time. So we had to find a way of working together. To the client, I became their project manager so that there was some control she had over the situation, and she could very much direct me in what she needed to have contact with her family, see her house, see her dog, be able to make some decisions. I was able to go and do home visits, having risk assessed everything and made reference, bringing that information back into the NHS environment, again virtually, so that the client could make decisions around home setup. As I said, it was a mid-terrace, it was totally unsuitable for independence at home, but ensuring that we were able to make those decisions as a family and a client with the team. We used virtual resource, be that WhatsApp, Zoom, laptop, FaceTime, whatever we could use to try and have the client involved in those decisions. Also, the client didn't know what sorts of questions to ask at that time. She's no reference point for disability, neither did the family. So helping them to consider some of the questions they wanted to ask. What does an ASIA diagnosis mean for my life? What do I need in my life to reduce this impact to me and my family? Who will guide that conversation for my family and I, and you know, to help reduce the fear and lack of experience. Mr. Desai mentioned psychological help. I was able to bring that to the family as well as psychological resource into the unit where actually they were really struggling with that staffing. Next slide, please, Becky. So as a case manager, it was really important that I was well informed and proactive in my role. I've already mentioned that I knew the spinal injury unit well. I worked with I knew the spinal injury case manager well. I knew the staff, I knew the protocols. But outside of that, within the environment of the legal process, I also needed to be able to ask some questions, and obviously refer to case law that has recently been finalised, which could assist the client and her husband and her boys and the dog to make some decisions about where they were going to go. Mr. Desai mentioned that the rehab was shorter than usual, and in that we needed to ensure that that there was case law such as Swift and Carpenter referenced to look at that this was a young client, they had equity in their property, could capital be released, early doors to be able to look at the revisionary interest working well for them so that the client could actually move into home short term. She didn't want to go into rental and then be able to look at purchasing a property to move into. Also, the stamp duty in June up to June 21 was something else we needed to maximise the opportunity to benefit from. And what did the client want to do with those accommodation choices? Did she want 3 steps with the family? So to move home, then rental, then look at properties? No, she didn't. She was very clear. She wanted to go home, see her house, say goodbye to her house, but during her inpatient stay, and whilst at home, very much be moving to her end property and being involved in every step of that, which the virtual platforms provided her with the opportunity to do with the other professionals that I was able to bring to that, with the funding provided by the insurer party under the joint referral that I was instructed under. Also ensuring, mentioned before, the social care services were all working remotely. So I ensured that we were looking at things like CHC early doors while she was in the spinal injury unit, making sure that there was funding for PA. We still didn't know the way liability was going to go, so we needed to maximise those fundings where possible and support the care plan, make sure that she had all of her benefits in place, and that the multidisciplinary team that was in place for the spinal injury unit was accessed where possible to endorse and evidence the need for all of these areas. Thank you very much. I think that is my last slide. Thanks very much for the opportunity today. I will be available for questions at the end of the presentation.
Thanks so much, Jo, for a very helpful insight into the case management role and being the link between the client and the services available to them, which was obviously very crucial last year. I have the absolute pleasure of introducing our final panellist, Owen Mitchell client John Adams. As John will tell you, he suffered multiple injuries, including a complete spinal cord injury at T3 in 2016. Highlighted with some great photos and videos, John is going to share his first-hand experiences of rehabilitation, both before and after lockdown, the ways he found to keep himself moving and the adjustments he had to make to his rehabilitation during lockdown. So I will hand over to John to bring us up to speed on what he's been up to.
John, you're just on mute at the moment.
How about that? Is that better?
Yeah, that's fine, thank you.
Sorry, on the 26th of June 2016, I was going to work on my beautiful BMW GS 1200, heading into Goodwood Festival Speed, where I managed Toyota's motorsport participation. The next thing I remember is waking up 6 weeks later in hospital, being told to stay still, and basically the story I was told is that the car pulled straight in front of me. I tried to avoid it, but hit the car and then ended up on the side of a building. The outcome of this was a badly broken lower left leg, a smashed pelvis, large number of broken ribs, a broken shoulder, and worst of all, a T3 complete spinal break, which meant basically I had to lay flat and not move. And as I'm sure you understand, this was not easy to do. I've learned since the only real reason I was alive is due to the amazing air ambulance that picked me up and flew me to Southampton Hospital, where they put my pelvis back together. 2 weeks later, I went to Salisbury, they put my leg back together. And then a month later, I was transferred to Stoke Mandeville, where at the end of September, the wonderful Mr. Black bolted my spine back together, T1 to T5. It was only after this that I was allowed to move and start my journey in a wheelchair. I can remember the day really well, the 7th of October 2016, as I was really keen to get out of bed, as it had been 4 months, and start my rehab. As you all know, the NHS was under serious pressure even before COVID, which meant I only had 1 hour in the gym Monday to Friday. Of course, I wanted more, but that was the limit. I think I got to go to the hydro pool 4 times during my rehab while I was there. I managed to get discharged on the 2nd of February 2017, 7 months after arriving to hospital by helicopter, and slowly but surely it was sinking into my stubborn head that life had changed dramatically, and keeping fit was no longer just using the gym of life, which I'd done in the past. Before my accident, I was 6'2", 96 kilos. When I first got in a wheelchair, I was 76 kilos, and all of a sudden I was 4'2", which is one of the hardest things to accept when you're being tall. Before leaving hospital, and after a lot of research, Sue, my wife-to-be at the time, had managed to find a local physio who specialised in spinal injury, called Nikki Penny and Jackie Patman, who taught hydrotherapy. Both Jackie and Nikki knew each other, and between them they put together a brilliant programme which was knowledge-based to get me back into the real world. The first video, please, Becky. In between work and life, I managed to fit 2 physio sessions a week, 1 strength and 1 core, which were both about 45 minutes each. As you can see from the videos, they were quite intense and not really for the faint-hearted. Nikki is great, as she knows so many things about the human body which still amaze me. She's always asking me at what level I'm working myself, and I wear a polar heart rate monitor for every session, which displays live on my phone. This gives Nikki the chance to adjust the sessions accordingly. Personally, my favourite is the strength session, but I know how important the core session is, but it's just really hard on the brain, as you want to do it easily, but your lower body just won't do what you want it to do. My sessions have slowly evolved over the last 4 years, and they will continue to do so, as I'm using the massive knowledge base that Nikki and her team have built over the years of working with various disabilities. I remember during my case, there was a lot of pressure from the other side for me just to use a normal gym. But luckily, Tracy, my solicitor, said it was up to me. And what was important for me was my long-term health and my physical condition. I know there is plenty of research into this out there, but my experience has shown that a normal PT would just never have the knowledge that Nikki and her team has. Just as a bit of an example, really, if you broke your watch, which is basically made of nuts and bolts, would you take it to your local mechanic to fix? No. It's horses for courses, and I'm sorry to say, but we are very special. Second video, please. Once a week, I do a 1-hour hydro session with Jackie, which she has built and continues to build for mobility and strength training in a low impact environment, which we do in a 33-degree hydro pool, which is perfect for me. As a lot of you know, the big issues with wheelchair users is everything is concentrated on moving the wheelchair around, which is one type of movement, the shoulders and arms in a forward motion. Again, the studies have shown long-term issues with this is damage to the shoulders, and the last thing you want with a spinal break is to lose one of the 2 limbs that you have left. Jackie's sessions are all about keeping my shoulders mobile in all the areas, building those little muscles you would possibly not need unless you were training for a specialist sport. Jackie has adjusted my sessions to suit my changes in ability and strength over the last couple of years. I also use my polar heart monitor in the water to keep a record. Getting in the pool once a week is it's one of the few times I feel like an able-bodied person, where I can swim and nobody knows that I'm paralysed from the chest down. I love my hydro sessions. I've tried using a normal pool, but it's just too cold. So let's move on to the crazy world that hit us in March 2020. As the weeks and months rolled on, it's strange to hear people complaining about being locked in their houses. This is my normal life since my accident. There is not one of my friends or family's homes I can get into without help. And this is before we start on shops and restaurants. I guess 7 months of being locked in a hospital was very good training for lockdown. From my side, all of a sudden, my life gym, like everybody else's, was closed. I was really worried, as I didn't want all my hard work to go to waste. Luckily, Nikki set about getting her online really quickly, and after a lot of hunting on the internet, I found some weights, some bands, a good gym mat, and once again it was over to Sue, as I needed help to do my online Zoom training. Hydro was put on hold until the summer, when I was lucky enough to be able to use a friend's outside pool, and which is where Jackie's expertise really showed, as she had worked hard on teaching me how to use my time in the water, and most importantly, how to get in and out of different pools safely. Just down the road from our house is a tennis club, which was closed during lockdown, but it gave me the opportunity to push up and down their car park, which has a bit of a slope on it. I worked out basically 20 times up and down the car park, and a push home equaled 5k, which got my heart rate up and gave me the chance to get my daily exercise during those first few months of lockdown. Near the end of lockdown, I met the tennis club chairman in the car park, and he asked me if I'd ever considered playing tennis as the courts were accessible. I said I hadn't, but I was up for the challenge. One of the hardest things was to find a tennis wheelchair. A new chair can cost a few £1,000s, and if you don't take up the sport, it's money down the drain. Luckily, after a bit of searching, I found a second-hand frame, and being an engineer, I did it up, found some wheels and cushions which were missing, and tennis is fun, and it has a great social side to it. Amazing enough, just when I thought things would be okay, we entered into lockdown 2, which was completely different as it was winter time. Luckily, Nikki had her gym all PP'd up, and Jackie managed to talk to the owners of the pool I use, and they agreed it was a therapy pool, so we could continue to use it. This was not only been good for keeping my body into shape, but also you cannot underestimate the part it plays in maintaining my mental health. One of the other bits of equipment I now have is a hand bike. After doing quite a lot of research, I worked out that Stricker, the German manufacturer, made hybrid hand bikes, which you could attach to your wheelchair without having any extra brackets fitted, which is really important for me as I want a lightweight daily chair. The hybrid is also important as Brighton, where I live, is like Rome, built on 7 hills. So basically, wherever we go, there is a hill to get home. Third video, please. I managed to order my new hand bike last December, and being an engineer, the first thing I did when it was arrived was to see how I could bring it up to the 21st century, as the twist gear change setup it had really looked like it came from the Ark. To be honest, this is a common issue with disabled equipment, as manufacturers seem happy to use old technology for most of the time. I did quiz them about using a state-of-the-art electronic change as used on modern bikes, but they said it would not fit. Well, that's red rag to a bull to me. So a month later, we were out cycling on the seafront with less cables flapping around and a fantastic gear change system operated simply by my thumb. I really like the bike as it now gives me the ability to go out and not only get a bit of exercise, but also give me the chance to cycle with my wife. On top of this, if we arrive somewhere like a coffee shop, I don't have to wait outside. I can take the bike off in a couple of minutes, lock it up, get in the cafe, in my wheelchair, and enjoy being like any normal, able-bodied person. As mentioned earlier, I was 6'2" and loved being tall. One of my goals has been to get back to those dizzy heights, which I worked out I could do with an exoskeleton. Now, you need deep pockets and people who believe in you, as it was made clear to me at the beginning that to use an exoskeleton, you need to answer a few questions. 1, weight, okay? 2, height, just in, I'm 6'2", so I fit in there. 3, injury level, below T4. Oh, well, T3, T4, surely there can be no difference. Well, this was my thought, but everybody else, apart from my great team around me, said you need core to use one of these. Fourth video, please, Becky. Well, after about 50 hours of training in the rewalk, which has been combined with a special training program put together by Jackie and Nikki, I now have my own suit and love every minute of a walking tour. What's important here is not only about the physical exercise of things, it's about the mental side, as this is a brain drug. It makes me feel so good. Yes, I get up and we walk around with Sue behind me for about an hour on the seafront or in the local hall if it's too cold to go outside, but that 1 hour recharges my mental battery and makes me feel good inside. On top of this, I'm told it will help towards keeping my bones in good order. I do stand in my standing frame 4 or 5 times a week for about an hour each time, and this is static, but to be honest, it's like watching paint dry. I completely get at the moment with technology how it is. I cannot use the rewalk on my own, but future technology will change and we will be ready for that. COVID has not helped in moving forward, but I have managed to stay fit and healthy and continue building my strength. One of the things I've learned over the last 4 years is to get a real mixture of exercise. Yes, I love doing my physio and hydro with Jackie, but this is just a building base for getting out and living my life. Doing tennis, using my handbike, or just going for a push along the seafront with my wonderful wife. The moral of this whole story is for people who work with spinal or brain damaged individuals, whether you're a lawyer or a carer, treat everyone as an individual. Anything is possible if you set your mind to it to achieve your maximum potential, especially if you have the knowledge-based team around you who understand the challenges we all face. The world will open up again, and like the exoskeleton technology, I want to be there ready to take the next step, as rehab is not just a few months, it is a lifelong mission. Thank you for listening to my story.
Thank you, John. That was absolutely brilliant, and it's great to see you applying your engineering skills. But also, I agree with you in respect of the psychological impact of exoskeletons and other devices. That cannot be underestimated. So we're going to start the Q&A. I'm going to come to you first, John, with our first question, which is, what advice would you give to clients who are nervous about lots of support coming into their home and feeling institutionalized?
Chani, thank you. I think from my experience, I would say basically you need to own it yourself. You need to take control of the situation. Unfortunately, a spinal injury is there for life. It's not something which will just pop away after a while. If you're not happy with the people around you, change those people to have them to make people which you want to have around you. That's the most important thing.
Thanks, John. Anne, over to you.
Hello again. This is a question for Mr. Desai, and it's about those top-up rehab sessions you mentioned earlier. Do you have any advice for spinal cord injured patients who are waiting for admission for those top-ups? What sort of advice can you give them about maintaining independence and well-being while they wait?
Thanks, Anne. Yeah, that's a very good question. I would definitely advise them to focus on two things. One is their psychological health, because as John said, rehab is a lifelong mission, and I think I completely agree with him. This is admission to a specialist spinal unit or somewhere privately for a couple of weeks or a few months is not end of the story. You need to continue it to keep yourself fit and live life as you wanted to live, of course, with disability. So number one, psychological health. Usually our patients would form a group of like a WhatsApp group or chatting group when they are in the unit, in a specialist unit. And I've seen many of my patients, they keep talking to them and they get, they exchange their experience and their views and they get the peer support by that. So that's the one thing which keep them going. If someone has done something new, they would start doing as well if the facility is available. The second thing is before coming to top up, a spinal unit usually gives a good discharge summary document where a lot of exercise protocols are discussed. A lot of videos would be there with the patient, what they did in the spinal unit during their first episode. And I would advise them to continue as much as they can. I mean, not everybody has a facility to get through the claims or money or anything like that. We are talking about 80% of our patients who are not having that facility. And those group of patients should be doing what they were advised as much as possible. That's all. And I strongly believe that you need to get somebody like a reasonable physiotherapist. I mean, neurophysiotherapist, if you get somebody, you are lucky, but sometimes it's someone to motivate you in case if you are deep down. because that is very important. Otherwise, a lot of patients would lose their kind of an energy to go forward. That's what I would advise. Thank you.
Thank you, Manish. One more question for you. Post-pandemic, do you see anything changing in respect of delivering rehabilitation? You mentioned the introduction of technology and virtual consultations. Are these here to stay?
I am very much thinking that it would stay, and during this whole year or more than a year, I kept asking all my patients, which I did virtual consultations or telephone. Some of them, they said that, oh, this is brilliant because we don't need to travel 120 miles each way or 100 miles, and we can do this. And they would themselves choose a face-to-face appointment where they really need to see a consultant, then they would book that slot. So there are a group of patients who want to continue like this, who are more or less stable 5 years post-injury. They are in the routine and they know exactly what to do when they need spinal help. So that is the part of the patients would continue, but we need to see patients. I'm desperate to see my first patient in outpatient. Actually, my psychological health is affected because I'm not seeing my patients, right? It is not the same as you do virtual consultations. Because we all are human beings, we have got emotions. We need to ask them what did you do outside spinal cord injury. I've got 5 minutes in my consultations when I talk about other things to my patients, and those things are less likely happening because of the pressure, because of the virtual. Similarly, a lot of patients would be getting virtual therapy assessments and outpatient-based therapy programs, I would say, because this has been successfully used by a lot of therapists, case managers, and I'm sure that would continue over a period of time. So a lot of things would change, obviously. People would be more prepared for episodes like these, like pandemics or similar kind of things in healthcare scenario. And now we have got robust infrastructure to help our patients and see how we get them through this injury and rehabilitation. Thank you.
Thanks, Manish. Can I ask John the same question? From your perspective, how have you found virtual consultations and appointments?
Chani, yeah, to be honest, I have to say my year end, I normally have one checkup a year at Stoke Mandeville, and my appointment, it took quite a long time to get it sorted. And then, of course, because I couldn't go there and have any scans or anything else, I had to arrange for them to be done locally, which my doctor has been amazing about trying to help and sort it out, my local GP. I have to say, I think it's been quite hard, actually, and I had to push really hard to get. And I do feel for patients that don't have possibly the dedication and the say stubbornness to keep pushing hard on this. You can quite easily give up because unfortunately COVID has been used as a massive excuse for customer service. And yeah, it hasn't been easy, Chani, but we are getting where we need to get to.
Thanks, John. I'm going to come to Joe. Joe, we've got two questions for you. The first question is, what challenges have you faced during the last 12 months in terms of maintaining support to clients? And the second question is that you referenced the need for early collaboration with all parties involved. Can you just comment on how important that is in order to implement early rehabilitation?
Mm-hmm. I'm going to start with your second question first, really. I felt that was really critical because as Mr. Desai was talking about, there were all sorts of challenges in the transition from the trauma unit to the spinal injury unit, and I felt that the referral was made very, very late. So in order to understand as a case manager what we were dealing with and what resource we could pull on very, very early, that meeting was extremely important, and also working with the unit to understand what they were able to provide, with a lot of the therapies being delivered virtually, especially the psychological follow-up, not just for the client herself, but her family, because they hadn't been able to see her, touch her, be in the same space, understand that transition. For all case managers, I think is something we can broker really early, and that was incredibly effective at delivering resource and overcoming that. In terms of accessing services outside, this particular client was able to go on to a rehab unit further to her spinal injury unit admission. But again, it's been about risk assessing everything, finding out what was most important to the family. I was her project manager, as I mentioned before. So as John was saying, she and the family needed to direct me to what was most important to them in that transition, and taking my lead from the rehab prescription and the spinal injury unit in terms of what she was ready to do. And then finding specialist rehabilitation providers within the geographical area that we could ensure were reaching into the unit and making sure that that transition of rehab happened very proactively, so that by the time she was in that second stage, which was home before her final home, she was actually getting services coming in with full PPE and carrying on that rehabilitation strategy with what limited equipment she was able to get into the home. But the case manager was very much the person running around in the background, making sure the money was there, making sure the resource was provided in the priority that was hers, really, and that the unit endorsed.
Thanks, Jo. I'm going to move on. I've got a couple of questions actually for Jane. Firstly, there's been a question about the waiting list to be seen by NeuroConnects. Is there a waiting list? And secondly, someone's asking, how do they get onto one of the trials or any research projects that might be available? And how do they find out about the criteria for going on to those research projects?
Okay, thanks, Jo. So let's talk about the clinical trials first. Probably the best place to look is a website called clinicaltrials.gov, which lists all the trials that are currently happening in the UK, and it gives a little bit of information about each trial, who could be included and who will be excluded, and there should be contact details on there as well, so you can have a look at in your geographical area what's happening, or more generally what's happening in the UK. And then the second question was about waiting lists. We try and get people in within a couple of weeks after them being referred to us or applying to come and start with us, because we know that it's sometimes hard for people to take that first step, and we don't want them to lose that kind of strength to get in through the doors and get cracking. So ideally within a couple of weeks. We're really busy at the moment, which is great as things start to open up after COVID. Lots and lots of people are desperate to try and get moving again. So we are busy, and some of availability depends on times of the day. Obviously the middle of the day is really busy, but there are often slots in the mornings and evenings that are available. So sometimes harder to schedule in people who are coming in for from a little bit further away. If they want to come and do an intensive block with us, like every day for a week, that takes a little bit more planning, but just for 1, 2 or 3 sessions a week, then we can normally manage something quite quickly.
Thank you. Well, look, thank you to all of our speakers. I found the presentations to be very insightful. The last 12 months or so have been very challenging for all of us, but I'm inspired to hear the stories of our clients, but also the teams that support them. And I echo John and Jane's view that rehabilitation is not something that has a start or an end for those with a spinal cord injury. It's an ongoing process and a lifelong journey. Collaboration is quite clearly absolutely necessary with all relevant parties to implement early and effective rehabilitation. Thank you to all of you for joining us. If you have any further questions, please do get in touch. Our contact details are on the screen now. Please visit irwinmitchell.com for details of future webinars and legal updates. And finally, I'd be grateful if you could take 2 minutes to let us know your feedback. The link on the form, link to the form should be on your screens now. Thanks again for joining.